1 in 2 Americans will hear these words at least once in their life. You need surgery. And here's what nobody tells you in that moment. Studies suggest that between 10 and 20% of surgeries performed in the United States every year are medically unnecessary. For spinal surgery alone, more than half of lumbar operations have been judged unjustified by independent review. That is over 2 million operations a year performed on bodies that did not need them. This is not a rounding error. This is a systemic failure. And the reason it keeps happening is simple. The system profits from you being on the operating table. It does not profit from you getting better without one. I'm Dr. Marcus Reid. I'm 58 years old. I practice in Boston and I specialize in metabolic health, brain function, and aging for adults in their 50s, 60s, and beyond. I'm not here to tell you that surgery is never the answer. Sometimes it absolutely is. What I'm here to tell you is what should happen before you ever reach that table, and what I've watched happen in 28 years of practice when it doesn't. If you've ever been told you need surgery, without a second opinion, without a full conservative workup, without anyone asking why, this video is for you. Subscribe to Dr. Marcus Reid and hit the like button. What I'm about to share, a private clinic has no financial incentive to tell you. Let me start with the most important principle in all of surgery. Surgeons know it. They rarely say it out loud to patients. The best operation is the one that was never performed. That is not weakness. That is not laziness. That is hard-earned medical wisdom. The moment a scalpel touches your skin, the clock cannot be reversed. Scar tissue, the dense fibrous material your body lays down to seal any wound, does not disappear. It remodels the mechanics of your body. It compresses neighboring structures. It restricts blood flow. It is permanent by definition. That is why every physician worth their credentials should be asking one question before booking an OR. Have we truly exhausted every conservative option? Because once you go under the knife, that question has no more answers. Here are the 5 operations I see performed most often without sufficient justification, and what you should be doing instead. Operation number 1. Spinal disc herniation surgery. You come in with low back pain. You get an MRI. The report says herniation, and within days, a surgeon is telling you that you need an operation. Here's what nobody tells you at that appointment. If you took 100 completely healthy Americans off the street, no back pain, no complaints whatsoever, and MRI'd their lumbar spines, roughly 50 of them would show a disc herniation or protrusion. Half the population. Walking around. No pain, no idea. Which means the image on the scan is not your diagnosis. The image is a finding. The diagnosis requires a patient who is suffering in a way that actually matches that finding. And even then, surgery is rarely the first answer. Here is when disc herniation surgery is genuinely necessary. There is one situation that qualifies as a true emergency. Cauda equina syndrome. That is when compression becomes so severe that you develop progressive leg weakness, loss of bladder or bowel control, or numbness in the groin and inner thighs. That is an emergency. You operate. But it is rare. The overwhelming majority of herniation cases involve chronic low back pain and sciatica, nerve pain radiating down the leg, that responds to conservative management. Here is the physiology. Your spine is a stack of bones separated by discs, thick, gel-filled pads that distribute pressure between the vertebrae. When the loading is symmetric, the disc stays centered. But when your pelvis is rotated, when deep stabilizing muscles are in chronic spasm, when old trauma has shifted your body's mechanical balance, the pressure becomes asymmetric. The disc gets pushed harder on one side and bulges out the other. That bulge is the herniation. Here is the critical question nobody asks before surgery. If you remove that bulge but do nothing about the asymmetric loading that created it, what happens? Your body needs a buffer, so it builds another one, at the level above or below. Within 2 or 3 years, you're back in imaging with a new herniation at an adjacent segment. This is not a surgical complication. It is a predictable biomechanical consequence of treating the symptom instead of the cause. The published data confirms this. A prospective cohort study comparing surgical and conservative treatment for lumbar disc herniation found that surgery offered faster pain relief at 6 weeks, but at 1 year and 2 years, outcomes between surgical and non-surgical groups were statistically comparable. A meta-analysis confirmed the same pattern. Surgery wins short-term. By 24 months, there is no significant difference in pain or function. The reoperation rate after disc surgery runs between 8 and 12%. That is 1 in 10 patients back on the table. What I find extraordinary in clinical practice is that the duration of suffering almost doesn't matter. I have seen patients who have carried low back pain for 10, 20, 30 years. When you restore proper pelvic mechanics, release the muscular tension, and correct the biomechanical loading, the pain resolves, sometimes within a handful of sessions. 30 years of suffering, resolved in weeks. That never stops being remarkable to me. What to do before agreeing to spinal surgery? Find a qualified musculoskeletal specialist trained in biomechanics, not just imaging. Work through a genuine conservative course of treatment that addresses the mechanical cause, not just the pain. Only if you develop progressive neurological deficits, worsening weakness, or bowel and bladder changes that fail to respond to real rehabilitation does the surgical conversation become urgent. Operation number 2. Hemorrhoid surgery. Hemorrhoids are swollen veins in the rectum and anus, essentially varicose veins of the lower digestive tract, and they are extraordinarily common. Surgeons are often quick to operate, especially when there is active bleeding. Yes, surgery works. The data shows higher rates of symptom resolution and lower short-term recurrence compared to conservative care. I am not disputing that. But here is what that data does not address and what I want you to think about. I treated a patient, middle-aged man, hemorrhoids with active bleeding, visibly anemic. He had already been referred for surgery. He came to me because spending a month flat on his back, out of work, out of his family's daily life, was something he couldn't accept. What I found on examination was significant visceroptosis. That means his internal abdominal organs had descended lower than their normal anatomical position and were pressing down into the pelvis, directly onto the venous networks around the lower bowel. Blood could not drain upward against that pressure. It stagnated. The veins engorged and ruptured. He also had an old coccyx injury. When the tailbone is traumatized, it can block the normal subtle motion of the sacrum, the large triangular bone at the base of your spine. In normal physiology, the sacrum performs small rhythmic movements that assist venous drainage from the pelvis. Block that motion, and you accelerate venous congestion. He also had a restriction in the occipital bone, the bone at the base of the skull. Here is an anatomical fact that surprises most people. The skull base and the sacrum are mechanically linked through the dura mater, a tough fibrous tube that runs the full length of the spinal canal. A restriction at the top affects mobility at the bottom. A head injury can, through this mechanism, contribute to blood pooling in the pelvis. We addressed all of these layers. The bleeding stopped. Surgery was never needed. I am not telling you hemorrhoid surgery is never appropriate. In advanced disease, surgery is clearly the right choice. But there are cases, and I have seen enough to say this with confidence, where the mechanical contributors have never been evaluated. If your surgeon is sending you to the OR without assessing organ position, without evaluating sacral mobility, without asking about old tailbone injuries, that is an incomplete workup. And even when surgery is ultimately necessary, correcting those upstream mechanical factors beforehand dramatically improves the outcome and reduces recurrence. This is not instead of surgery. It is before surgery. The distinction matters. Operation number 3. Surgical repair of diastasis recti. Diastasis recti is a separation of the two parallel bands of abdominal muscle along the connective tissue seam running down the center of your abdomen. It appears most commonly in women after pregnancy. The abdomen visibly domes outward when rising from lying down, and when the separation reaches 6, 7, 8 centimeters, surgeons frequently recommend an operation to suture the edges back together. Here is what I have watched happen in practice. Women told they need surgery begin a supervised program of corrective core rehabilitation, designed specifically for diastasis, not crunches, which make it worse, but deep stabilization work targeting the inner core and pelvic floor. Within several weeks, a separation of 7 centimeters is down to 3, without anesthesia, without a scalpel, without scar tissue, without 6 weeks of post-operative restrictions. The surgical indication disappears with exercise. The physiology explains why. Muscle is living tissue. It responds to mechanical stimulus. The right loading pattern, appropriate intra-abdominal pressure management, progressive strengthening of the deep core, causes the connective tissue to remodel and the muscles to migrate back toward midline. This is not theory. This is exercise physiology in action. Now consider what surgical repair cannot do. A surgeon can mechanically approximate the edges with sutures, but that does not restore muscle strength. It does not rebuild the neuromuscular connection between your nervous system and the muscle fiber. It does not improve coordination. If the muscles remain weak after the repair, the separation can recur. The structure is physically closed, but the function is not restored. If someone tells you your diastasis requires surgery, pause. Get a referral to a pelvic floor physiotherapist with specific diastasis training. Follow the program honestly for 2 to 3 months. The result may save you from an operation entirely. Operation number 4. Venous surgery for varicose veins. This connects directly to what we just discussed, because the mechanism is the same one that drives hemorrhoids. Visceroptosis, the descent of abdominal organs into the pelvis. Picture the veins of your legs as a low-pressure return system. Blood climbs back toward the heart against gravity, pushed along by the calf muscles and a series of one-way valves. Now imagine that your abdominal organs have descended and are pressing down on the major venous vessels of the pelvis. This is exactly like applying a tourniquet at the top of your thigh. Pressure below the compression point rises. The veins distend. The valve leaflets, delicate and designed for low-pressure operation, begin to fail. Blood pools, venous walls stretch, spider veins appear first, then ropey, bulging varices. Modern vascular surgery offers laser ablation, sclerotherapy, and mechanical stripping. All produce good cosmetic results. The bulging disappears. The leg looks better. But if the visceroptosis driving the elevated venous pressure has not been corrected, the same pressure gradient builds new varices within 2 to 3 years. I hear this from patients regularly. I've had it done twice, and it came back again. That is not a surgical failure in the technical sense. That is a systemic failure to address the cause. How do you know if organ descent is part of your picture? Stand relaxed in front of a mirror. If your abdomen protrudes forward in a way that doesn't match your overall body composition, a relatively lean person with a noticeably protruding lower belly, that is a sign. Her organs have shifted downward. This is not just a cosmetic issue. Pelvic varicosities, leg varices, hemorrhoids, back pain, and bladder symptoms can all trace part of their origin to this displacement. These are not separate problems. They are one anatomy. The right approach. Correct the organ descent first, address nutritional deficiencies, strengthen the supporting musculature. At early stages, this alone can stop progression entirely. When surgery is warranted, restoring pelvic mechanics beforehand means the surgical result holds. 1 operation instead of 3. Operation number 5. Surgical repair of pelvic organ prolapse. This is the surgical lifting and anchoring of a descended uterus, bladder, or rectum. It is a significant procedure, and most women who reach the point of needing it have been ignoring the problem for years, sometimes decades. The mechanism is a two-sided failure. From above, visceroptosis, abdominal organs pressing downward. From below, a weakened pelvic floor. The muscles that form the base of the pelvis have been stretched, often by childbirth, sometimes by chronic straining, sometimes by inherited connective tissue weakness. The ligaments that suspend the pelvic organs have lost tensile strength. The uterus, the bladder wall, the rectum, they begin to slide downward, slowly, toward the vaginal opening. This is not an event. It is a slow, years-long migration, and that gradual nature is simultaneously the danger and the opportunity. The danger, people adapt to slow change. You stop noticing what has shifted until the shift is severe. The opportunity, at early and moderate stages, this condition responds well to conservative intervention. Pelvic floor physiotherapy, targeted rehabilitation, and structural correction of organ position are all evidence-based approaches to preventing progression. I had a patient with first-degree prolapse. Organs descended, but not yet at the vaginal opening. We began conservative work. Her symptoms improved substantially, and then life took over. She stopped. She came back 5 years later. The prolapse had advanced to the point where conservative management was no longer sufficient. Surgery was performed. The outcome was good, but she had missed a window that, if she had stayed with the program, would likely have kept her off the operating table entirely. I tell that story not as a criticism. I tell it because it is real, and because it illustrates what timing means in medicine. An early-stage prolapse treated seriously is a manageable mechanical problem. An advanced prolapse ignored is a surgical case. The intervention does not change. The stage at which you decide to act changes everything. Here is where age becomes genuinely relevant to everything we just discussed. After the age of 50, the connective tissue changes that drive all 5 of these conditions: disc degeneration, venous wall weakening, ligament laxity, fascial thinning, accelerate measurably. Estrogen decline in women after menopause directly contributes to pelvic floor weakening and increased herniation risk. In men, core muscle mass diminishes and lumbar loading patterns shift. These are not theoretical risks. These are changes I see on examination every single week. How old are you right now? Drop it in the comments. The advice I give a 38-year-old with a new disc herniation is meaningfully different from what I tell a 62-year-old with multi-level spinal changes. Your age helps me build the videos that are actually useful to you. Let me bring this together with the clearest, most practical guidance I can give you, the kind I would give you in my office. For disc herniation, do not consent to surgery because of an MRI finding alone. Surgery is justified only when you have progressive neurological deficits, worsening weakness, loss of bladder or bowel function, that fail to respond to a genuine, full conservative treatment program. That means months of real biomechanical rehabilitation, not a few sessions of generic physical therapy. For hemorrhoids, before agreeing to an operation, insist on a thorough mechanical evaluation. Is there organ descent? Is there sacral restriction? Has anyone examined your tailbone? These are not exotic questions. They are basic diagnostic steps that should precede any surgical referral. For diastasis recti, a separation measured on imaging is not an automatic surgical indication. Work with a pelvic floor physiotherapist for 2 to 3 months. Measure the gap again. You may find surgery is simply no longer on the table. For varicose veins, if you are in the early stages, spider veins, mild dilation, no skin changes, address the mechanical contributors first. If surgery is needed later, do it on a body where the cause has been corrected. One procedure done properly that holds. For pelvic organ prolapse, if your gynecologist tells you there is early prolapse, that is not the moment to wait. That is the moment to act. Aggressively, conservatively, immediately. Pelvic floor therapy and structural rehabilitation at Stage 1 can keep you out of the operating room for life. Waiting until Stage 3 takes that option away. In every single one of these cases, the key word is first. First, find the mechanical cause. First, exhaust the conservative options. First, restore the structural foundation. And then, if surgery is truly the only remaining path, go into it prepared. Go in with corrected mechanics, restored tissue quality, and eliminated upstream drivers. Then, the surgery is done once, and it holds. Everything I've covered today is for your education and understanding. Your situation is unique. Use this as a starting point for a real conversation with your physician, not a substitute for one. The long-term outcomes for conservative and surgical management of many of these conditions converge. Surgery sometimes gets you there faster, but your body, in the right conditions, often gets there too. Give it the chance to try first. Your doctor is not going to walk you through this at a 15-minute appointment. There is no billing code for explaining why you might not need an operation. That is what this channel is for. Subscribe to Dr. Marcus Reid. Hit the bell, and if you know someone who has been told they need surgery without ever being offered a real conservative alternative, send them this video. That conversation could change everything. I'll see you next time. Take care of yourselves. I mean that.